morning. Welcome to the Department of Medicine Grand Rounds. Today I want to remember Emil von Behring. Emil von Behring died on this day, March 31st, 1917, at age 63. He's considered the founder of the science of immunology. He did a lot of work for diphtheria, and he received the 1901 Nobel Prize for Physiology of Medicine, which I think was the first one for physiology of medicine for his work related to what he termed antitoxins. But today is about cancer. So what do we remember today? It turns out this week, Dr. Crawford W. Lung from Jefferson, Georgia, was the first to use ether in anesthetizing to taking a tumor off a patient. And what he did is he took the patient who had a tumor in his neck, and he soaked a towel with ether, put it on the face of this patient when he was asleep, just took the tumor away and ran out the door. And that was actually 4 years before Morton actually publicly described the use of ether. And today, Dr. Lung is recognized for being the discoverer of surgical anesthesia. I didn't know him, but I knew of him because there was a Crawford Lung Hospital in Atlanta where our residents used to go. You know him because this week you went to Doctor's Day at the hospital, and Doctor's Day was in honor of Dr. Crawford Lung. So I'm going to bring Dr. Lori Earnshaw up to the stage, but I want to use this opportunity before she introduces our speaker to thank Lori for her efforts at UofL. Some of you may know or may not know that Lori is leaving us, but not too far. She will remain in Louisville. She will remain in hospice. A couple of words. 2002 to 2006, she obtained her internal medicine and palliative medicine training here. In 2002, she joined the faculty as assistant professor of palliative medicine and fellowship program as the director of that. She became associate professor in 2012, and she became a fellow of the Academy of Hospice and Palliative Medicine, and she's done a lot of work to advance the understanding of what palliative medicine is at this organization. She runs a terrific fellowship program, and it's sort of nice that we have today sort of this presentation and Lori to introduce our speakers so that we have an opportunity to also celebrate Dr. Lori Earnshaw. Lori? So Lori, in recognition of your outstanding service to the University of Louisville Department of Medicine, thank you so much. Okay. And there's your division chief. So now go ahead and introduce our distinguished guest.
Oh, wow. Thank you all so much. That was unexpected and really appreciated. I'm going to miss everybody. But today is not about me as much as it is about my wonderful mentor, Dr. Laurel Lyckholm. And she is currently a professor a professor of internal medicine and division of Hematology, Oncology, and blood and bone marrow transplantation at the University of Iowa. And she's been there for just 2 years. And is already blazing trails there. She started out with a foundation in the humanities with her degree in English, like many of us, and so my other mentors I see in the audience. I'm so glad you're here today, you all. And has also had an interest in ethics and has completed her fellowship in clinical medical ethics from the University of Chicago. So she did her MD at Creighton, and followed by her internal medicine residency. And then she did her fellowship training in hematology oncology at University of Iowa. She spent most of her career at Virginia Commonwealth University, and that's when I came to know her as both a hematologist and a palliative care physician. She was a program director of not only the oncology fellowship program, but also the palliative medicine fellowship program. And she has been an inspiration to me as an educator, just a wonderful human being who was incredibly compassionate and loves teaching and loves learning. And I think she can be a model to all of us. So I could go on and on about all of her positive attributes and all the manuscripts she's published and the publications she's had, the presentations she's done, and all of the awards that she's received. But I would run the risk of embarrassing my very humble friend. So with that, I give you Dr. Laurel Lyckholm, who's going to talk about truth or consequences, prognostication in cancer.
Good morning. This is one of those subjects that's really contentious to some degree and really close to my heart, being a hemonc person and a palliative care person. And I think it's close to every single physician's heart, every single nurse's heart, every single social worker's heart. And I'm going to present some things to think about, maybe raise some consciousness to some degree, try to set this up so there's a little time for discussion at the end, and a little bit of a patchwork quilt about prognostication in cancer. Oops. I'm going to discuss reasons that the provision of accurate prognosis informs ethical cancer care, list the primary factors that determine prognosis in cancer, define performance status, and talk a little, just a tiny bit about Karnofsky and ECOG for anybody who doesn't use that or know it. Describe the ways in which prognosis may be best provided to patients and their loved ones. And I'd like to hear from you about how you do it. And then describe outcomes of prognostic disclosure. There have been a couple of really compelling studies that have been done recently, and I wanted to tell you a little bit about them. And how it affects people with cancer, how this discussion of prognosis sort of rolls out and affects people, patients and their families. So I want to start with the fact that provision of prognosis is really the only way to provide ethical cancer care. Without telling people the prognosis, you might as well just pack up and go home. It's the key to quality cancer care. There are a lot of practical reasons, obviously, financial planning, planning for children, planning for parents, all the things that you have to do when you're looking at a shortened lifespan that you're aware of. Deciding how and where to die is hugely important. And how many of you have read Atul Gawande's Being Mortal? Well, several. I would recommend it highly. I think his main thesis is really about how to live in the time that you have left and how important it is when you know that that time is short for a patient, that they know that too, so that they can make some choices. So a lot of this is about respecting autonomy, about giving people information so they can make the right decisions. And that's why it's so important and so incredibly important for really good ethical cancer care. And then kind of bringing this in, because I always want to bring it in because I think it's just so beautiful, is Ira Byock's 4 things that he always talks about that are part of the work of the dying, that people need time to do and time to think about. And that's to say to their loved ones, I forgive you, please forgive me, thank you, and I love you. And those things don't always just go in 4 seconds. They can go for days, and people have to plan to do that, and that's a really important thing for a lot of people. So I want to provide some cases to give context to this talk. The first one is a 61-year-old woman who was recently diagnosed with metastatic non-small cell lung cancer. She's been staying in bed longer in the morning. She often returns to bed after lunch, and she kind of stays there for the rest of the day because she's just shot. She's really tired. She's requiring more help to ambulate. She's no longer able to really vacuum, dust, cook, or clean. She's alert, but she's having some short periods of confusion, maybe brought about by the meds that she's taking, maybe not. Her family members have called to ask you if they should call the Red Cross to notify her son who's stationed in Afghanistan. So of the 4 factors listed below, which is the most important predictive factor in patients with cancer? Tolerance of treatment, performance status, sites of disease, or the type of cancer that the person has? If you could choose one. B, performance status. And can somebody just say why you think that would be the most important? Anybody? It's kind of early to be asking participation. Well, obviously, it's performance status, like everybody said. And we know that performance status, more than anything in the studies that have been done, and all those others were important too, but performance status really affects a person's survival, their prognosis. And I just wanted to remind you about the Karnofsky Performance Status Scale. It was first developed in 1948 and used for, especially to determine whether somebody could receive chemotherapy or could stand to receive chemotherapy. Back then, chemotherapy was nitrogen mustard. And as you know, I always think of it as 100% is they're out of bed and doing stuff 100% of the time, and 0, of course, they're dead. And between there, it makes me, I usually ask somebody, what percent of the time during the day are you out of bed or off the couch? Are you doing something? And I think that works out pretty well. Some of the things about Karnofsky that are really helpful is that you can think of a median survival as 3 months, as roughly correlating with a score of less than 40, or ECOG of 3, which we'll talk about ECOG too. And then hospice eligibility, of course, is so important, and maybe that's going to change, maybe it's not, and I hope it does, so that we can get more palliative care to people when we don't absolutely know their prognosis. It's really listed as Karnofsky score of 50% or less, but it will also include patients with a Karnofsky of 70% or higher if the patient has very rapidly progressive disease or declines therapy or doesn't qualify for therapy. And then here's our ECOG. This was back in the 70s and 80s, and it was also used by the Eastern Cooperative Oncology Group for their clinical trials, and also to sort of decide whether a person could undergo certain chemotherapies. And most, I think, as an oncologist, how many people here are oncologists? Not very many. So as an oncologist, I can tell you that if somebody tells me ECOG 3, I'm like, ooh, I don't think chemo is going to be, really working out for this patient unless it's really easy. And everything is changing because of all the targeted therapy, because it's so much, in some situations, easier to give and easier to tolerate. In other situations, not so much. So you can see that ECOG goes the other way, that the higher the score, the sicker the patient, the less functional. But it's also really looks at functional status. That's why it's called performance. So when we're thinking about clinicians prognosticating, it's hard. I would say of all the different sort of diseases, cancer probably has the most developed ways to prognosticate. People really have been working on this pretty hard. And there are really some great tools that we can use to prognosticate. So when doctors first say, oh, I don't know how long he has to live, how am I supposed to know? Only God knows, or only the being above, or whoever knows, but I don't know, I don't have a crystal ball. I just say, no, that's not true. I think we have some really great tools, and the closer the patient gets to dying, the better the tools really are. So a recent study by Christakis really showed, and he's showed this along with Elizabeth Lamont over and over again, that physicians overestimate prognosis, usually by at least a factor of 3, all the way up to around a factor of 6 or 7. And oncologists are really bad about this, or good about it, whichever way you want to look at it. One of his really seminal studies was in 2000, and it's in the BMJ, and there were 343 physicians who estimated survival, and these were physicians of different specialties, For 468 patients at the time of hospice referral, when the patients had a median survival of 24 days. Only 20% of those predictions were accurate. 63% were overly optimistic, and 17% were overly pessimistic. And some of the factors when they factored these out were that the female patients, certain medical subspecialists, lack of clinical experience, and longer duration of the doctor-patient relationship was associated with less accurate predictions. Does that make sense? So what they showed in this study was, and this has been shown over again, is that when the doctor-patient relationship was tighter or longer, there was more of a tendency to, would you say, over or under prognosticate? Give longer time or a shorter time? Longer, exactly. And why do you think that physicians overestimate prognosis? What are the reasons that you would tell somebody that they were going to die in 6 months instead of when in your head you really said, I know it's 1 month, and you've committed that to paper? You want them to, exactly. Is there any other reason? Yeah, you don't want to hurt them with sad information. Absolutely. You don't want them to get mad at you. You don't want them to fire you. I've been fired 2 times for giving accurate prognosis. That was long before I started asking people if I could give them a prognosis. That helped a lot. So we really have to be conscious of that. And there has been at least one legal case about overprognosis, about being overly optimistic. And it was this case that was actually reported in the New England Journal. And it was a patient with pancreatic cancer. And the doctor way overprognosticated. And the patient had some sort of a big financial arrangement going. And he kept the financial arrangement going. And when he died, his estate lost a ton of money that they wouldn't have lost if the doctor had sort of told him the truth. And that case was overturned, and then it was taken to a higher court, and then it was overturned again. And I think, though, eventually that the patient's estate, I think his wife actually won that suit. So I'm not saying that that's the reason ever to tell people the truth or anything like that, but I just wanted to bring that up because it was a case that was reported. Woody Moss, who's over at West Virginia University, really great nephrologist and palliative care physician, he asked 4 oncologists to estimate the 1-year survival rate of 853 patients using this question. This question is the surprise question. Does anybody know what that is? Can you say? Right, exactly. So would you be surprised if this patient was dead in 6 months? And how do we usually use that? I bet you use it for...
Yeah, we're looking at it now.
Oh, you are? Very good. Yeah. And we use it for hospice so that we can estimate whether a person really has 6 months or less, and we can be honest with the hospice providers and say, yes, I think this person has less than 6 months. I wouldn't be surprised if they were dead in 6 months. So I think that they're eligible for hospice. Does anybody else use it for other reasons? Yeah.
Sure. First of all, I use 1 year because I think the original surprise question, would you be surprised if this patient died in 2 years? Since doctors overestimate prognosis and drops it down.
That's a good point.
It could be a trigger for having to go on care.
Oh, that's really good. Exactly. Yeah. Thank you. It is a helpful way to identify patients to have that trigger for various things, but it isn't very precise and it's very subjective, obviously. And there have been several people who have written papers about how subjective physicians are based on a person's gender, their socioeconomic status, et cetera. So that's something that you have to also be prepared to sort of grapple with, is that sort of, bias. And prognosis is a process. It's not an event. It keeps going, and it sort of morphs as the person changes and gets, say, sicker, or they have some sort of an event. Early on, it may be driven, in oncology, it may be driven by cancer biology. When you're looking at either, the type of cancer that they have or the way the cancer is behaving from the get-go, the treatment response. And then it becomes to be sort of a more factored in with or by events that the patient has. So their performance status, how it changes, delirium, dyspnea, cancer, anorexia, cachexia, those things you'll hear about again are really important, and they really affect the prognosis. And as you're taking care of this patient and you get to know them, and you see that they're developing one or more of these things, or that they now have had 3 pneumonias, or et cetera, the prognosis changes. And so it's an ongoing sort of activity, and it should be an ongoing discussion with the patient as well. A 57-year-old woman is admitted to the hospital with dyspnea and a large left upper lobe mass with multiple liver metastases. She's found to have adenocarcinoma of the lung. On the early morning of her discharge home, she's found pulseless and unresponsive. A code is called, and she is revived and intubated. On the 3rd day after her arrest, she remains on the ventilator, and although sedation has been slowly withdrawn, she remains unresponsive. Her family nervously awaits a family meeting, which the palliative care team has been invited to attend. The current discussion revolves around her current full code status. Her son, an engineer, says, well, she survived the first time. Why not do it again if necessary? What do you think of that? Yeah.
I have a personal idea that I'd like your feedback on, where it's a mama and I call, I love mama too much to let her go. And I think that can be a bit blinding, because relationships with family and the patient about prognosis and pragmatism and reasonable assessment by reasonable physicians and applying it to your level. I'd like that may be part of that. You succeeded last time. I might not have a reasonable expectation about her metastatic disease. I might not have a reasonable expectation about her resuscitation. So that's what I think about.
So what would you do in this case? What would you say to him?
I would counsel about suffering and how can we help her best. And if the best way to help her is to minimize her suffering, then maybe putting her through defibrillations and broken ribs and prolonged intubation and tracheotomies and biopsies and surgeries might be a better way to help her.
It sounds like you've had some experience saying those things. And how does that usually play out?
Families like to help their loved ones, and they don't like prolonged suffering. And so if it is in the, I find that if it's in the venue of helping without prolonging suffering, oftentimes families have a bit of a light bulb, even though pragmatist engineer doesn't want his mother to suffer. But if rather than mechanical discussions about, the ventilator is less, but the ventilator, if you change the focus towards how do we help her best, we're not going to be able to cure her cancer. We may be able to avoid the trauma of another resuscitation.
How do you help her best? That's a great line. I like that. I mean, that's really, that really helps. And it seems to me, from my experience, that sometimes, and anybody please jump in. Where's Lori? that sometimes they're like, no, we just want to keep going, and we want her to have full CPR and all that, and you walk away, and you come back in a few hours, and they're like, oh, we've been talking. We don't want that. Does that happen to you?
Yeah.
Does that happen to anybody else? That there's a time factor, and I always tell the house staff, just wait, just give it a few hours. And also different people that come to visit, I have this theory about the mayonnaise jar lid, that everybody kind of twists it a little bit, and you can't get it off, and then all of a sudden, it's always the palliative care team that comes in and takes off the lid. But it's true. They hear it from various people, and especially the nurses. Oh, are so helpful. Oh my gosh. Who said yes?
I did. I mean, that's what I found. The nurses are there, and they're listening to these discussions. They're at the bedside constantly, especially in the ICU. And they just give little different pieces of information, and I feel like that helps the mayonnaise jar a lot. And then they can identify the time when those family members are open. Like they identify, I think we have an opening here.
Yeah,
like
the window.
Time to talk,
Exactly.
Like there's one family member who really gets it, who happens to be here. Maybe it's the time. So I found that the nurses are a vital part of this process.
Yeah. Yes.
I love your thinking this as a process that unfolds over time. And even going into the discussion, if your goal of the discussion is to determine code status, you're missing a whole lot of other things that this meeting is really about.
Yes.
To get a shared understanding of what's going on, to build a relationship with the family, to understand more what the patient's wishes, what are feelings and quality of life, and that kind of thing. And so you don't have to get to the code status answer for it to be a successful meeting.
Exactly.
You start to unscrew the lid off the basic of what's happening.
Exactly. Yeah. Yeah.
You made a point of saying engineer in that structure. So often you need to reframe it from the never framework to the likely unlikely.
Likely unlikely.
Because so much of our ethical discussions have lawyers' background to them, which don't ever be not the likely unlikely. And you completely reframe this question.
Yeah.
And I totally agree with the process.
Yeah. Language is so important, so amazingly important, the things that we say. And we can really derail something really fast if we say it the wrong way or the right way. So which of the following factors does not predict a failure to survive discharge after CPR in the hospital? Dementia, metastatic cancer, serum creatinine greater than 1.5, or myocardial infarction? Did you say B? D. And why D? Who said D?
Because you can usually fix it. I mean, usually MI, you can take them to the cath lab and fix it. So you reverse it. You help with the heart, not trying to coach someone who is a heart disorder that the body's not.
Exactly. Yeah. So all those others are things that people have been sort of somewhat devastated by, or at least living not as well with. And then an MI is something that is very acute. Not that it may have no effect, but that's absolutely right. And I was going to talk a little bit about CPR and survival, but I'm not an expert on it, and I know very much that these types of chronic diseases really affect the outcome of CPR, but I don't know the data well enough to talk about it. But I know there are people in this room that do, because Lori told me. You're seeing a 41-year-old woman with breast cancer, metastatic to the liver, bones, and lungs. She has worsening pain in her mid-back. She's more tired than usual. She has developed morning headaches that tend to dissipate during the day. She's resistant to pain medications as she feels they make her feel loopy and more tired. She's stopped working as a cashier, and she's spending a bit more time on the couch at home. She's able to do some lighthouse work, but no more than 20 minutes at a time. The cancer has rapidly progressed through 3 standard protocols of chemo and 2 clinical trials. She's a single mother and has 3 children, ages 7, 10, and 15. She hopes to see her 15-year-old graduate from high school in 2 years. What do you tell her? She's this lady, she's got this big, huge grin on her face talking about her child graduating in 2 years. What is her backup plan if that doesn't happen? Have you tried that one out? So to me, that would be a reasonable, but I think you're telling her that it could happen that she lives 2 more years, and likely, so you don't want to hold something in front of her that you can't offer. That's the only thing. What's that? How would you do that? Anybody else? Can you say how you would help to set a more realistic goal? Because that's a really good, that whole reframing idea is, the big one is reframing hope for living for 3 more years and reframing it to hope for having a really good, 2 weeks where every day is pain-free and gets to be spent with people you love. That whole idea of reframing. So that, I think, goes with what you just said. Yes?
I love the idea of reframing. If you think of this in terms of time, and she's saying 2 years, if you want to say, yeah, that's not realistic, but the goal isn't about time, it's about my 15-year-old son graduating from high school. So if I started to inquire more about what does that mean for your son,
Oh.
graduating from high school, what are your feelings about your son, what are your hopes for your son, we might identify other things we can start working on right now rather than be focused on this one time you might have in relationship with your son.
That's wonderful. Yes. Oh, go ahead. And then you. Absolutely. She does need to know the truth. Yes.
You want to get an understanding of what she knows about it.
Yes. Absolutely. Absolutely. That's a great point. We haven't even talked about teams and team members and how they can all help. It's not just one person ever. Yeah. And I think I just continued the case, and this is basically sort of what you would approach her about. And she says, what kind of time am I looking at? I might be able to beat this back for a few more years. And then you've got a lot of work to do. So asking her, that was at just finding out what she already knows, what you were just saying. She already knows that she has a couple more years to go, which she doesn't. So the single most important predictive factor, as we talked about, in advanced cancer is performance status. How much a patient can do for themselves, their energy level, their activity level. Patients with solid tumors typically lose 70% of functional ability within the last 3 months of life. And we know that curve that, and I don't have a slide of it, but that for cancer survival, and the trajectory goes sort of like this, and then it drops off in the last couple months and the last couple weeks. And we always are able to tell, and that's why I said I think it's really important that we realize that we have a lot of tools to help patients. And one of those is knowing those trajectories. And the one for cancer really does go like that and falls off. And we see it over and over again. And when the patient says to me, what's it going to look like? I can tell them, you know, you're going to go along pretty well, and then you're going to start noticing that your energy is falling off some, and then one day you're not going to want to get out of bed, and then it's going to be a pretty short time after that if you don't get out of bed the next day or the next day, and then you know that time is very short. And that's really helpful to think about those trajectories. Now, for people that have that are pulmonary and cardiac specialists, I'm not sure that it's as good because it seems to go a lot like that, and it's a lot more unpredictable. Is that correct, you think? Who's a pulmonologist here? So just, you know, pulmonary lung, people with chronic lung disease, COPD especially, just have a less predictable course, you know, prognostically. And I don't know if that's ever improved. And I think also with chronic, you know, congestive heart failure.
Well, I was thinking about your conversation because I'm a critical care guy. And often these conversations, unfortunately, take place in the ICU when they should have been taken care of in the clinic,
Yes.
at home, in the hospital floor, ends up in the hands of the critical care doctor trying to decide what to do with a ventilated patient who probably doesn't have much more to live, but he's on now being kept up to the life. So these conversations happen all the time. And what people don't realize sometimes is that COPD, chronic lung fibrosis, and all these other chronic lung conditions, their outcome is not that very different than lung cancer. And so we hear the word cancer, and initially we talk about prognosis, but we hear the word severe COPD, and we don't think about that. And we probably should be thinking about that at the same level, the same degree.
Yeah, I think that's true, and it's true also of chronic dementia, you know, like Alzheimer's, very much like lung cancer. And I think we don't think of that either. So there's some prognostic tools, again, in advanced cancer. The one that we use quite a bit in palliative care is the Palliative Performance Scale, and it uses actually the Karnofsky, and these have been validated, by the way, for cancer patients. They're not as valid for other types of patients, but they're also being tested now, so hard to know. But it looks at ambulation, activity level, self-care intake, level of consciousness. And then there's the Palliative Prognostic Score. And again, looking at the factors that factor out with these different prognostic tools is really helpful because they help you to look at the patient and say, well, that's not going very well, so that's probably a bad prognostic indicator, et cetera. The PAP, I think, was developed in Pittsburgh, and there's a lot of P's in there, by the way. Originally developed for prognostication in solid tumors, it's also been shown to be reliable in patients with non-cancer diagnoses, unlike the PPS, organ failure syndromes, AIDS, and neurologic disease, but it hasn't been validated in the larger studies. And this is the Palliative Prognostic Score, and you can see that these are the indicators: dyspnea, anorexia, Karnofsky, clinical prediction of survival, white count, which is very interesting, lymphocyte percentage. So the lower the lymphocyte percentage, the higher the score, and the higher the score, the lower the survival. So I thought it was very interesting that when they did the study that fell out, the lymphocyte percentage. But it kind of makes sense because then there's all those neutrophils. Some questions that you can use to assess functional status, at least that I use and I think are very helpful, and just the asking of them may help start a good conversation. Or how do you spend your time? How much time do you spend in a chair or lying down? Are you able to dress yourself, et cetera? Are you working? What's bothering you the most? And the survival time is affected adversely by increasing numbers of physical symptoms, as we know. And it's interesting because almost every person with metastatic cancer that has been studied has at least 5 symptoms at any one time. And dyspnea is a really bad one. That's a really bad prognostic indicator in cancer. Some cancer syndromes overall, and there are a lot of caveats to this. Malignant hypercalcemia, except in some cancers like myeloma and breast cancer and lymphoma, where they present with that but actually can live quite a long time after they have had their initial presentation and are treated. Malignant pericardial effusions, carcinomatous meningitis, multiple brain metastases, and steroids may improve, but there's no definitive evidence that they actually help a person live longer. They certainly help a person live better in many cases of people with brain mets. And then malignant ascites, except maybe in some ovarian cancers and a few other types of cancer. The 4Ds that there's a paper out of Houston that talks a lot about, they use this a lot, the 4Ds, decreased performance status, which is sort of sneaky, dysphagia and cancer anorexia cachexia syndrome. And I have to say, and I'd love to do this study, and maybe will someday if I have enough time, that when you see somebody with temporal wasting in cancer, I don't think they ever come back from that. I don't think it ever turns around. I think it's a pretty good indicator. But I've never been able to find a study that showed that. But they actually use hand grip strength and maximal expiratory pressure as indicators of how bad their cachexia is. Delirium, waxing and waning, altered mental status over the course of a couple of weeks is a really bad indicator in extensive cancer. And then dyspnea. Dyspnea seems to be a really bad prognostic indicator. 67-year-old man sees an oncologist for a newly diagnosed stage 4 pancreatic cancer with mets to the liver. They talk for some time about treatment. The patient says, "I'm just not sure I want to go through chemotherapy. What are my chances?" Stage 4 pancreatic cancer with metastases to the liver makes me really stand up and really pay attention and go straight to, talking. I'm going to just go through that. Talking with the patient about their prognosis. What do patients understand? Well, Jane Weeks, who I think is I want to say she's in New York somewhere, she looked at 1,100, 1,200 patients with metastatic lung or colorectal cancer. 74% of them failed to understand that chemotherapy was unlikely to cure. So they either didn't hear it, it was said, but they didn't hear it, or it was never said. And that's a hard one to figure out. Some outcomes of prognostic disclosure. There was a study by Doherty, who's at University of Chicago, who showed that that prognostic disclosure, that life expectancy, I don't know what I associated with more realistic patient expectations. Yes, so better quality of life is associated with more realistic patient expectations of life expectancy. And we actually did a study at VCU where we showed people who had extensive stage colon, lung, and prostate cancer what their prognosis was based on their stage, which was all 4. And then we sort of fairly quickly did I don't know if you've ever heard of the Hope Hearth Index, but it's a survey that shows people's level of hope. And we did it before and after, and actually their hope didn't go down much. And most of them said, "Thank you for showing this to me," which was really pretty cool. And I don't know if any of you have ever sat down and had a prognostic discussion with someone and been thanked, even when you told them that they had a terrible outlook or outcome. And although a vast majority of oncologists tell patients if their cancer is incurable, and this was from this survey that they did of these oncologists, only 43% reported discussing life expectancy. So they said it's incurable, but they didn't talk about how long they had to live. So when you sit down to tell this patient who says, nobody's really talked to me, this happens all the time in oncology, nobody's really talked to me about how long I have to live. It's often the family that says that. How long does he have, doctor? They follow you out of the room. They say, can we talk for a minute? So how long does he have? Does this sound familiar? So first of all is when to tell. I'm not a person that is going to sort of shove it down their throat. They'll almost always find their time that they want to find out. The patients will. They'll find their time that they want to ask you. The patients' families will ask you right away, how much time? I always warn, and this is my only slide that comes straight from me, so I didn't get this from a study, but I always warn of the seriousness of what we're about to talk about. Obviously, we're going to have to talk about something really serious here. And that gives them a chance to sort of steel themselves a little bit. Or I wait for the patient to ask also, like I said. I ask permission of the patient and the family, and I always say, can we talk about some really tough things? And can we talk really straight? Absolutely, I want it straight, doc. Every single time. What do you know? Here's your question. What do you know already? What do you think is going on? What kind of time are you thinking that you have to live? And then you tell it in plain language, and I know this is starting to sound like Breaking Bad news stuff, and it is. I use holidays sometimes. I sometimes say, I think we're going to make it to Thanksgiving, but I'm not sure we can get through Christmas. And get through, I hope that doesn't sound too obscuring. People usually understand get through. I don't give specific dates. I don't know anybody who does. But time frames, 2 to 3 months, weeks to months, months to a year. And then it's often a good segue into advanced directives, even code status discussion. If the window seems like it's open, that open window, if it's open a little bit and you feel like you can go through it, but a lot of times they've had it, and you walk away and say, well, I'll be back tomorrow to talk some more, and let's talk about this a little bit more. And maybe that's when you come back to talk about the code status. Just all depends. You just have to be so sensitive. And I know I've heard a few people by just being so like, I've got to get this done. I've got to get this done. I got to get this code status done before next week or before, he gets sicker or whatever. And I don't think that's very good. And then there's this wonderful article by Enzinger and Pragerson, who does a lot of this work. 726 patients, 17% reported their physician had disclosed prognosis. 71% wanted to be told their life expectancy. So big difference between 17% and 71%. Prognostic disclosure was not associated with a worried or anxious mood or likelihood of meeting criteria for major depression or generalized anxiety disorder. So we're always like, oh, don't tell them. They're just going to fall apart. They're going to commit suicide. They're going to, they can't take it. And this study and several others have sort of debunked that. They can take it. It depends on how you do it. If you're gentle and it's the right time, I think, and you have enough time, don't just, run in and run out. I think you can do it. So patients with a realistic prognostic understanding are not only more likely to prefer comfort-oriented care, but also more likely to engage in advanced care planning. Another great reason to talk about prognosis. And patients who perceive themselves to have a longer life expectancy were less likely to complete a living will or appoint a healthcare proxy. So you're not doing them any favors by giving them a longer time than you really think they have. And then I just want to play this video for you. They'll probably send this really home better than I could do it all.
Just gonna stand there and watch me burn. End of life and all my wishes go unheard. They just prolong me and don't ask why. But it's not right,
can't tell you what I really want. You can only guess what it feels like. And right now it's a steel knife in my windpipe. I can't breathe, but you still fight, cause you can fight. Long as the wrong's done right, protocol's tight. High off of drugs, try to sedate. I'm like a pin cushion, I hate it, the more I suffer. I suffocate, right before I'm about to die. You resuscitate me, you think you've saved me, and I hate it. Wait, let me go, I'm leaving you. No, I ain't. Tube is out, you put it right back. Here we go again. It's so insane, cause though you think it's good, I'm so in pain. I'm more machine than man now, I'm Anna Kane. And no advance directive, I feel so ashamed. And crap, who's that nurse? I don't even know a name. You lay hands on me to prolong my life again. I guess that you must think that this is living.
Just gonna stand there and watch me burn. End of life and all my wishes go unheard. They just prolong me and don't ask why. It's my right to choose the way that I should die. The way that I should die.
Z-Dog MD.
The way that I should die.
This ain't easy. Get the family. You ever love somebody so much you can barely see when you with them that they lay sick and dying, but you just don't want to let them be at peace cause you miss them already, but they ain't gone. Beep, beep, the ventilator alarms. I swore I'd never harm them, never do nothing to hurt them. Hippocratic oath, primum, not no surrender. Now I'm forced just to torture them. They push full code, no one knows what his wishes were. His sister heard him say once, I don't want to be a vegetable. But no one agrees in the family. The caregiver Kate wants some comfort care, but Aunt Claire lives so far away. That her guilt eats her like a cancer, so she answers, wait, I think you'll wake. Ma'am, you ain't even in the state. Palliate, relieve pain, get him home, explain. Critical care, just hypocritical when it's so insane. But they insist I shock his heart against a persist. I guess that's why they say that love is pain.
Just gonna stand there and watch me burn. End of life and all my wishes go unheard. They just prolong me and don't ask why. It's my right to choose the way that I should die. The way that I should die. The way that I should die.
What did you think? I think so too. And I think it's our brave new world of our residents, who I see a few here, and our medical students. And this is how they learn and how they communicate. And I think, and this is just, to me, the first time I saw it, I just was really tearful. So, oops. My summary is there are many valuable tools to help prognosticate in cancer, especially in late stages. It's difficult to discuss, but we owe it to our patients and families as really good ethical care. It assists with planning and decision making. And as survival shortens, we also know that time becomes more precious to people. And I'm not sure how many people really want to spend their last few weeks sitting in clinics waiting for their chemotherapy to come versus, going to their grandchildren's house or to their kids' barbecue or whatever. And I think when we think about those things, that's sort of what what Atul Gawande talks about too is that's his whole thesis, is letting people really decide what they want to do with this precious time that we know they have. And I think that's it. Hopefully I didn't put too many people to sleep. So, thank you.
Thank you for, stay up here. Where are you going? Where are you going? So I had two comments for you and a question. One is that I think, and I've mentioned this to this group before, this concept of telling the patient the truth, which I very much believe in. I still believe it's a Western concept. There are some cultures that don't appreciate that. Number two, I think that there are ethnic and racial groups that are more suspicious about doctors than others, and that therefore the approach, you know this, therefore the approach may take more time or a little bit different. I wanted to ask about the process and the concept of DNR. I do think when we got to the point of asking people whether they wanted to be resuscitated or not, advanced the conversation. Now that we're many years later, I think it's delaying the conversation. I think it allows people to take away the responsibility. It's easy to ask somebody, do you want to be DNR? It is difficult to have this conversation. So now that we have this concept, the residents and the doctors just feel comfortable. I ask them the question and we sign the paper, and we're done. We've taken away the responsibility. It is tough to have this conversation. We suffer through it, and it shouldn't be any other way. This is about the life of an individual. What do you think about this process?
Oh my gosh, I totally agree. It's not about the DNR. It is about that discussion, what you were talking about, that discussion that you have, and forget the DNR for now. I mean, you're legally bound, I guess, to have the DNR and all that. Now it's becoming allow natural death, maybe. We're moving into the age of A and D instead of DNR. But I totally agree. And about the cultural issues, that's when you get to know the people really well and develop trust if you can. I think it's really hard for ER doctors because they don't have that time to develop the trust, and that they have to really work really hard to do it really fast.
Questions, comments?
I just want to say thank you. I think it's really good to raise awareness of this issue because it creates a lot of discomfort, I think, so many of us, not even being taught how to do it and being taught to do it. So I hope that our future generations are going to do better job. But I think that's what you said. I think it's so valuable. I think we get so fixated on code status. And the way I like to frame it to patients with
Louisville